Looking at this slide for urinary assessment, percussion of the kidneys, palpation and percussion of the bladder, and inspection of the urethral meatus and perineum are important parts of the physical assessment of the urinary tract. A distended bladder would sound like a dull thud. Assessment of the patient should include palpation of the abdomen for masses, obtaining a urine specimen to rule out a urinary tract infection, and asking the patient about the frequency of bladder emptying. Abdominal masses can press on the bladder, which can cause a frequency. Incomplete bladder emptying can also produce frequency. Teaching is a nursing intervention and not a component of an assessment. Daily fluid intake. For the patient on fluid restriction, this is calculated by allowing 500 mL with a max of 650 for insensible losses such as respiration, perspiration, and bowel losses, and then add the amount of excreted urine or what is lost in vomitus during the previous 24 hours. A patient that has uremic frost, and this comes from itching from irritating toxins and deposits of calcium phosphate that's on the skin. Bathing the patient in cool water will remove crystals, decrease itching, and promote patient care. An antipyretic cream could be done to relieve the itching. Fluid intake is usually restricted for a patient with chronic renal failure. Hydronephrosis. This is a problem of urine outflow obstruction. The kidney enlarges as urine collects in the pelvis and kidney tissue. The patient would be experiencing urinary retention. Urinary retention, which occurs in hydronephrosis, can lead to fluid volume overload. Failure to treat the cause of the obstruction could lead to infection. Causes of hydronephrosis include stones, trauma, congenital structural defects, tumors, and fibrosis. Pain occurs from the obstruction, irritation to the ureters, and damaged blood vessels and renal tubules. Acute kidney injury. The primary goal of treatment is to eliminate the cause and provide supportive care while the kidneys recover. Because the patient's heart that might fail because of acute kidney injury, the care would be directed toward treatment of the heart failure. Prerenal azotemia. This is defined as elevated blood levels of nitrogenous waste products and one of the manifestations of acute proliferative glomerulonephritis. Acute proliferative glomerulonephritis is characterized by hematuria, proteinuria, azotemia, and salt and water retention. The urine appears brown or cola-colored, and salt and water retention leads to hypertension and edema, primarily of the face. Dependent edema of the extremities may also be noted. Anuria would be a complete absence of urine production, and anuria can occur in prerenal, intrarenal, and postrenal causes. Oliguria, or low urine output, could also indicate impaired kidney function. Dysuria means voiding that is either painful or difficult. Glomerular filtration rate. This is a preferred method for evaluating kidney function. The BUN levels can fluctuate based on factors such as fluid volume status. Urine output can be normal or high in patients with acute kidney injury and does not accurately reflect kidney function, and creatinine alone is not an accurate reflection of renal function. Because creatinine is an endogenous waste product that is filtered at the glomerulus, passed through the tubules, and excreted in the urine, creatinine clearance is a good measure of the GFR. To calculate the creatinine clearance, urine is collected for 24 hours. The serum creatinine level is measured midway through the collection, then the creatinine clearance is calculated using the formula volume of urine in mLs per minute times the urine creatinine in mLs per deciliter. The normal adult GFR ranges from 120 to 200 mLs a minute. A decreased GFR is associated with renal dysfunction and increases the risk of adverse cardiovascular events. Glomerulonephritis. Expected lab findings in a patient with chronic glomerulonephritis include proteinuria with casts and red and white blood cells. Failing renal function is evidenced by increased blood urea nitrogen, increased creatinine, and increased uric acid levels due to the accumulation of the byproducts of metabolism. Electrolyte alterations include metabolic acidosis, increased potassium levels, increased phosphate levels, and decreased calcium levels. Ketones may be found in the urine in patients with poorly controlled diabetes or alcoholics, fasting, starving, or consuming high-protein diets. Nephrectomy. A healthy person with good kidney function and a low risk of certain disorders such as high blood pressure or diabetes is a good candidate for donating a kidney to someone who needs a transplant. A transplant recipient who receives a kidney from a living donor has a better chance of survival than a person who receives a kidney from a deceased donor. Home care teaching. focuses on protecting the remaining kidney, including measures to prevent infection, calculi, hydronephrosis, and trauma. Patients should avoid contact sports and use measures to prevent motor vehicle accidents and falls that could damage the kidney. Monitoring weight is a concern for a patient after a kidney transplant, and note any signs of rejection and maintain prescribed fluid restrictions is a concern for the patient after a kidney transplant. Nephrectomy tubes. Care includes irrigation and should be performed only with an MD order. Using more than 5 mL of solution could cause overdistension and renal damage. Output and surrounding tissue should be assessed for signs of infection. The nephrectomy tube drains urine from the kidneys, so the tube must be kept below the flank level to prevent backflow of urine. The nephrectomy tube drains urine from the affected kidney. The urinary drainage device will drain urine from the bladder collected from the other kidney. To determine kidney function, drainage from each tube should be recorded separately. Nephrotic syndrome. The characteristic manifestations of nephrotic syndrome are peripheral edema, massive proteinuria, hypertension, hyperlipidemia, and hypoalbuminemia. Furosemide is administered to reduce the edema and help lower the blood pressure. A low sodium diet reduces fluid retention. Measuring girth and extremity size will assist in evaluating effectiveness of the interventions. Small frequent meals should be offered to improve intake. A low to moderate protein diet, 0.5 to 0.6 grams per kilogram per day, is prescribed because even though the damaged glomerulocapillary membrane causes a loss of plasma protein, a high protein diet exacerbates urinary protein losses. The pH of urine is useful in determining whether the kidneys are responding to acid-base imbalances. A lower than normal pH value indicates the urine is acidic. A higher than normal pH value indicates the urine is alkalotic. Polycystic kidney disease. Children of parents who have autosomal dominant form of polycystic kidney disease have a 50% chance of inheriting the gene that causes the disease. Blood pressure control is necessary to slow the progression of the renal dysfunction and reduce cardiovascular complications. Antihypertensive agents include ACE inhibitors, calcium channel blockers, beta blockers, and vasodilators. The patient could have bright red or cola-colored urine if a cyst ruptures. Sharp intermittent pain occurs when a cyst ruptures as well. A patient with the polycystic kidney disease can have salt wasting and should not be on a sodium-restricted diet. When renal impairment results in decreased urine concentration with nocturia and low urine-specific gravity, the patient should drink at least 2 liters of fluid daily to prevent dehydration. Protein appears in the urine if the glomerular membrane has been damaged, such as in glomerulonephritis. The specific gravity is an indicator of urine concentration. Urinary tract infection. Lower urinary tract infection would be cystitis. Upper urinary tract infection would be pyelonephritis. Now with pyelonephritis, the typical symptoms are high fever, chills, tachycardia, tachypnea, nausea and vomiting, abdominal discomfort, which is often colicky, flank pain on the affected side with costovertebral angle tenderness, generalized weakness, nocturia, urinary burning, urgency, and frequency. The kidney is palpable at the costovertebral angle. Serum creatinine levels are an indication of kidney function. The higher the creatinine level, the more impaired is the kidney function. A renal ultrasound may also help determine whether kidney problems are acute or chronic. Normal-sized kidneys may be present in either condition, but when both kidneys are smaller than normal, chronic kidney disease is usually the problem. Documenting liquids and foods. Obviously, liquids would be documented as intake, but food that turns liquid at room temperature should be counted as fluid intake. Pudding does not turn to liquid at room temperature. Coffee and cream are liquid, so those amounts taken will be recorded as fluid intake. Weight would be the best indicator of a patient's fluid balance. The urine collection bag should be kept below the level of the bladder to prevent reflux of pathogens from the bag into the urinary tract. Gloves should be worn for self-protection. Daily catheter care should be performed to remove pathogens and reduce pathogenic populations. Cleansing first the perineum, then the catheter, and then the rectal area prevents contamination of the urethra and catheter with pathogens from the rectal area. Securing the catheter to the patient's thigh decreases movement, which can cause urethral friction and irritation. An older adult could be at risk for falling. Avoid leaving a patient on the toilet for more than 5 minutes, and a patient should be taken to the bathroom at regular intervals, like every 2 hours. Spacing fluids at regular intervals throughout the day and limiting fluids after the evening meals helps to avoid fluid overload on the bladder and allow urine to accumulate at a steady pace. Running water uses the power of suggestion to promote voiding. Intermittent catheterization is preferred over inserting an indwelling catheter if the patient has a full bladder and is unable to void. Prerenal, the blood flow to the artery is diminished, perhaps due to a narrowing in the renal arteries or due to a state of shock. The kidney never gets a chance to do its filtering, and the failure is prerenal. Hypovolemia would be considered a prerenal cause of acute renal failure, as would sepsis. Drug toxicity would also be considered a prerenal cause. Intrarenal, if the kidneys become seriously infected and cannot filter, the failure is considered intrarenal. Postrenal, when the urine is produced and it has nowhere to go and is obstructed, perhaps by a tumor of the ureter, bladder, or prostate, pressure builds up in the kidney and causes damage. This is postrenal failure. Another cause for postrenal failure would include prostatic enlargement. When doing a renal assessment, obviously after your ABCs, then look at assessing for pain. Unrelieved pain can prolong the stress response. The nurse should treat pain before a physical exam or sending to a patient for a test or to do patient teaching. The nurse would inspect the abdomen and urethra for gross bleeding. The flank would be palpated for symmetry. If bleeding is present, the abdomen should not be palpated. Once the physical examination is complete, the patient should be prepared for a CT scan. Another priority would be to teach the patient about signs and symptoms of a UTI. Urinary incontinence. Stress incontinence. This can happen when there's an increase in abdominal pressure, such as when they exercise, laugh, sneeze, or cough. Urine leaks due to weakened pelvic floor muscles and tissues, and causes of stress incontinence would include pregnancy and childbirth, which cause stretching and weakening of the pelvic floor muscles. Other factors may also increase the risk for stress incontinence, such as being overweight or obese and having a prostate surgery. Urge incontinence is often referred to as overactive bladder. They have an urgent need to go to the bathroom and may not make it in time, leaking urine. Causes of overactive bladder include damage to the bladder nerves, the nervous system, to the muscles, and conditions such as multiple sclerosis, diabetes, Parkinson's disease, and stroke can affect the nerves, leading to urge incontinence. Other conditions such as bladder infections, bladder stones, and use of certain medications can also contribute to the symptoms. Overflow incontinence is not able to empty the bladder appropriately. As a result, they may have leakage once the bladder is already full. This is more common in men with symptoms of frequent dribbling of urine. Causes of overflow incontinence include weak bladder muscles, blockage of the urethra, such as by prostate enlargement, and tumors that cause obstruction of urine flow and constipation. With functional incontinence, physical problems such as arthritis or cognitive problems such as dementia prevent the patient from getting to the bathroom on time. Kegel exercises are pelvic floor muscle exercises, and the purpose of a Kegel exercise is to decrease incontinence. Tightening and then relaxing the pelvic muscles for 10 seconds each strengthens the pubococcygeal muscle that supports the pelvic organs. Cystoscopy allows visualization of the bladder and urethra that usually do not show up well on x-rays. Small bladder stones and some small growths can be removed during cystoscopy. The bladder lies directly behind the pubic bone, and a full bladder may be palpable above the symphysis pubis. The nurse should assess for urinary retention, which is a complication following a cystoscopy. The physician should be notified if the patient has decreased or absent urine output or is passing blood clots. If the patient's bladder is full, non-invasive methods such as running water should be attempted first. Although temporary inability to void may be expected, the patient should be assessed to determine that the bladder is not full. Complication of cystoscopy, hemorrhage. Blood-tinged urine would be an expectation after a cystoscopy, but bright red bleeding and clots are abnormal and should be reported to the healthcare provider. Bladder irrigation, antispasmodic medications would help reduce the pain from spasms and contractions of the bladder and sphincter. Extracorporeal shockwave lithotripsy. Some bruising may occur on the flank of the affected side after the extracorporeal shockwave lithotripsy because sound, laser, or dry shockwave energies are used to break this down into smaller fragments. Once the patient has recovered from the effects of the sedative, food and fluids are given. Increasing fluid assists with the passage of the shock fragments. There is no incision with extracorporeal shockwave lithotripsy. However, a small incision would be made during a percutaneous ultrasonic lithotripsy. A stent would occasionally be placed in the ureter before extracorporeal shockwave lithotripsy to dilate the ureter and ease passage of the stone fragments. The stent placement prevents the stone from coming in contact with the ureteral mucosa, which would reduce pain. The stent is not removed until the stone fragments have passed. Intravenous pyelogram is commonly done to identify diseases of the urinary tract such as kidney stones, tumors, or infection. It is also used to look for problems with the structure of a urinary tract that were present from birth, which would be congenital. The contrast dye used in intravenous pyelograms is potentially nephrotoxic, and concurrent use with other nephrotoxic medications such as nonsteroidals should be avoided. IV fluids are used to ensure adequate hydration, which helps reduce the risk of contrast-induced renal failure. The patient would not have to be catheterized prior to the IVP, only if they were unable to void. And it's important to do teaching that warm sensation could be felt when the dye is injected. And the best way to promote excretion of the dye is fluids. A renal angiogram is an angiogram of the blood vessels of the kidneys and may be used to assess the blood flow. A fluoroscopy is often used during a renal arteriogram, and a fluoroscopy is a study of moving body structures similar to an X-ray movie. A continuous X-ray beam is passed through the body part being examined and is transmitted to a TV-like monitor so that the body part and its motion could be seen in detail. After an angiogram, you have to hold pressure, direct pressure, for at least 5 minutes. Direct pressure is required to control bleeding before removing the dressing to check the puncture site. A complication would be that this would hemorrhage. A compression dressing is not sufficient enough to control arterial bleeding. Flexing the leg would be contraindicated because you can dislodge an already partially formed clot and then initiate further bleeding. Urine should be cultured to identify the causative organism and the number of bacteria present. Urine should be collected before antibiotic treatment begins to avoid skewing the results. Once the results of the urine culture are obtained, the antibiotic may need to be changed to one to which the causative agent is sensitive. Using the appropriate antibiotic also prevents antibiotic resistance. A broad-spectrum antibiotic is usually ordered but should be started after a urine culture is obtained. Patient teaching. Patient needs to avoid caffeine-containing beverages such as coffee, tea, cocoa, and alcoholic beverages because it irritates the bladder and should be avoided. And this is especially to help them avoid UTIs. Synthetic underwear and constrictive clothing such as tight jeans should also be avoided. The patient should urinate after intercourse. Acute renal failure is usually caused by an event that leads to kidney malfunction such as dehydration, blood loss from major surgery or injury, or the use of medicines. Most cases of acute renal failure occur in people who are already in the hospital for other reasons. In these people, acute renal failure is usually diagnosed with routine tests and shows a sudden increase in creatinine and BUN levels. A buildup of these waste products in the blood points to a loss of kidney function. Chronic kidney disease, usually by long-term disease such as high blood pressure or diabetes that slowly damages the kidneys and reduces their function over time. Symptoms of chronic kidney disease may not develop until very little kidney function remains. Other problems may develop with chronic kidney disease such as anemia and increased levels of phosphates in the blood, hyperphosphatemia, along with complications caused by kidney failure. These complications often do not develop until kidney disease has been present for a long time. AV fistulas are much less likely to clot than grafts, although it takes longer for them to mature to the point where they can be used for dialysis. The choice of an AV fistula or a graft does not have an impact on needle size or patient mobility. The presence of a thrill or a bruit indicates adequate blood flow through the fistula. Pulse rate and quality are not good indicators of fistula patency, and a blood pressure should never be obtained in an arm with the fistula. Irrigations of the fistula might damage it, and typically only dialysis staff would access the fistula. The difference between the three kinds of vascular access for hemodialysis are arteriovenous fistula, AV graft, and venous catheter. The fistula is an opening or connection between any two parts of the body that are usually separate. While most kinds of fistulas are a problem, an AV fistula is useful because it causes the vein to grow larger and stronger for easy access to the blood system. The AV fistula is considered the best long-term vascular access for hemodialysis because it provides adequate blood flow, lasts a long time, and has a lower complication rate than the other types of access. If an AV fistula cannot be created, an AV graft or venous catheter may be needed. Post-kidney transplant and acute rejection most commonly occurs in the weeks that immediately follow transplant. Renal artery stenosis manifests with a brewery over the surgical anastomosis site. Chronic rejection may develop months to years following a transplant. The presenting symptoms are progressive azotemia, proteinuria, and hypertension, and these are those of progressive renal failure. Renal tumors are often silent and have few symptoms. The classic triad is gross hematuria, flank pain, palpable abdominal mass, and is seen in about 10% of people with renal cell carcinoma. Hematuria is often microscopic and is one of the most consistent symptoms. If renal cancer was detected at an early stage and cure is anticipated, teaching should focus on protecting the remaining kidney, including measures to prevent infection, and avoiding contact sports such as football or hockey. Maintaining a fluid intake of 2 to 3 liters would also be part of the patient teaching. Risk factors for renal cancer include obesity, smoking, age greater than 55, and having a genetic predisposition to the disease. Males are affected more than females by a 2-to-1 ratio. A history of renal calculi is also a known risk factor. Types of kidney stones. Calcium kidney stones are made of calcium compounds, especially calcium oxalate. The calcium phosphate and other minerals may also be present. Conditions that cause high calcium levels in the body, such as hyperparathyroidism, increase the risk of calcium stones. Uric acid stones come from waste product normally passed out in the body in the urine. A diet high in animal protein, such as organ meats, poultry, fish, gravies, red wines, sardines, goose, and venison, are high in uric acid. Struvite. A frequent UTI is a predisposing factor for struvite stones. These stones are commonly referred to as infection stones because they form an alkaline urine that is rich in ammonia. Cystine stones are less common than kidney stones because it's made of a chemical called cysteine, more likely to occur in people whose families have a condition that results in too much cystine in the urine, cystinuria. The absence of colicky pain could indicate that a stone may have been excreted. And kidneys will continue to produce urine, and a patient should be voiding at least 30 mL an hour even with a calculi. Symptoms of a urinary stone would be abdominal or flank pain, usually very severe, hematuria, and renal colic. As the stone moves along the ureter, it produces that flank pain radiating to the genitalia and the groin. A ureteral lithiasis can cause a painful condition called a renal colic attack in which either one or both of the ureters become blocked by kidney stones. Renal colic due to ureteral lithiasis or kidney stones is often described as the strongest and most unbearable pain a person has ever felt in their lives. It is important to assess the colic pain, which is most severe in the first 24 to 36 hours and can cause a vasovagal reaction with syncope and hypotension. Increasing fluids will promote passage of a stone and decrease pain.